Hypoglycemia is an abnormally low blood glucose level below 50 to 60 milligrams per deciliter. It's caused by too much insulin or oral hypoglycemic agents, excessive physical activity, and not enough food. Signs and symptoms occur for two reasons. First one is an epinephrine release, and the second is a lack of glucose to brain cells. Our adrenergic symptoms include sweating, tremors, tachycardia, palpitations, nervousness, and hunger. And central nervous system's symptoms include inability to concentrate, headache, confusion, memory lapses, slurred speech, and drowsiness. Severe hypoglycemia, disorientation, seizures, loss of consciousness, and death. When we have hypoglycemia, we want to remember the 15-15 rule. This is how we treat it. We give 15 grams of fast-acting concentrated carbohydrate. That would be 3 to 4 glucose tablets, 4 to 6 ounces of juice or regular soda. We then retest the blood glucose in 15 minutes and retreat if it's less than 70 milligrams per deciliter, or if symptoms persist more than 10 to 15 minutes and testing is not possible. We are to provide a snack with protein and a carbohydrate unless the patient plans to eat a meal within the next 30 to 60 minutes. Emergency treatment of hypoglycemia is necessary if the patient cannot swallow or is unconscious. We will be giving subcutaneous or intramuscular glucagon, 1 milligram, or 25 to 50 mLs of 50% dextrose solution IV. And remember, this is very thick, it's hard to push, and we need to make sure the IV is good and working prior to administering this. DKA, this is seen more in type 1 diabetics because of the decreased insulin production. They're going to have hyperglycemia. There will be absence or inadequate amount of insulin, resulting in abnormal metabolism of carbohydrate, protein, and fat. The clinical features include hyperglycemia, dehydration, acidosis. They have a lack of glucose in the cell, then fats are used for energy, and this in turn produces ketones, and then this causes acidosis, and this would be metabolic acidosis. So in DKA, the pathophysiology is lack of insulin. On the left side, this is what happens in type 1 diabetes. So we have decreased utilization of glucose by muscle, fat, and liver. They have an increased production of glucose by the liver. Then they have hyperglycemia. This causes blurred vision, polyuria, and the polyuria leads to dehydration, weakness and headache, and increased thirst, polydipsia. On the other side, we have, this is the malnutrition route. So we'll have increased breakdown of fat, increased fatty acids, increased ketone bodies, acetone breath, poor appetite and nausea. They'll have acidosis, they'll have nausea, vomiting, abdominal pain, and increasingly rapid respirations. And in DKA, you're going to have blood glucose level greater than 300 to 1,000. The severity of DKA is not only due to blood glucose level, so the higher the blood glucose level, that doesn't mean they'll have a worsening case of DKA. It's actually the dehydration that makes it more and more dangerous. So ketoacidosis is reflected in low serum bicarbonate, low pH, and low pCO2. Will reflect the respiratory compensation. So they'll have Kussmaul respirations if they're in metabolic acidosis, with compensation. Ketone bodies in the urine and the blood. The electrolytes will vary according to the degree of dehydration. They will also have an increase in creatinine, hematocrit, and BUN. So acute kidney injuries go hand in hand with DKA due to the dehydration. So our goal is to rehydrate with IV fluid. We will be giving them IV continuous infusion of regular insulin. This is not IV push, this is a drip, and it will be only regular insulin. It can't be any other type of insulin. We will be reversing the acidosis and restore electrolyte balance. So rehydration can lead to increased plasma volume and decreased potassium. Remember, the insulin enhances the movement of that potassium from extracellular fluid into the cells, so we'll have to really watch their potassium level and replace that as necessary. We'll be monitoring blood glucose, renal function, and urinary output. They will be on ECG monitoring because of the potassium and the potential for dysrhythmias, and they will monitor their electrolyte levels, vital signs, lung assessments. So we're going to watch for signs of fluid overload because we're giving them a lot of fluids to reverse the DKA. They might get to where they are not processing it as well, and they will actually have fluid in their lungs or fluid overload. So that's something we have to monitor. Then we're going to monitor or review, the sick day rules. This is in your book. Make sure you understand it. This is what all diabetics should follow when they're sick. Sickness and illness is one of the number one causes of DKA, along with non-compliance with medical regimen. So hypoglycemia versus DKA. Hypoglycemia has decreased blood glucose. They have too much insulin. They have shallow breathing. They are cool, pale, clammy skin. We give them a carbohydrate followed by protein. In DKA, they have a high blood glucose. They have insufficient insulin. They have Kussmaul respirations. They have hot, dry, flush skin. We give them IV insulin, IV fluids, and potassium. Hyperglycemic hyperosmolar syndrome, or it's called HHNs. This is seen more in type 2 diabetics. It is caused by a lack of sufficient insulin, but the ketosis is minimal or absent. They will have hyperglycemia, and the blood glucoses will be higher than DKA. They're usually greater than 1,000. They will not have ketones. They will have enough insulin to avoid the use of fats for energy. Hyperglycemia causes osmotic diuresis. So even if it's 300, they're going to be peeing out more than a normal person. So just imagine if their blood glucose is over 1,000, they're going to be urinating excessive amounts of fluids. So they'll have loss of water and electrolytes. Remember, we pee out all of our good electrolytes. They will get hypernatremia, so that's an increased sodium, and they have increased osmolality. So the manifestations include hypotension. Remember, if they have all the fluids out, they're going to be hypotensive. They're going to have profound dehydration. So this is going to be seen in our kidney functions. They're going to have an increased BUN and creatinine. They'll have tachycardia. When we don't have enough volume to pump around, our heart goes faster. And they'll have variable neurological signs caused by cerebral dehydration. So they have urinated out all of their fluid. Their brain is even becoming dry. So this will cause changes in the LOC. This is a very high mortality rate with this illness. The treatment is the same as DKA, except they will use lower doses of regular insulin IV drip. So Samanji versus Don phenomenon. This happens in our patients who are receiving intermediate acting insulins instead of the long acting insulins. So this is for patients who take NPH. So the Samanji is when they have hyperglycemia in the morning. They might be having excessive evening insulin, and their low fasting glucose will be between 2 to 4 a.m. It'll be low. So our treatment is to decrease their evening insulin dose. And then the dawn phenomenon, they have hyperglycemia in the morning. Their evening dose might be wearing off, and their fasting glucose may be normal or high between 2 to 4 a.m. So our treatment is to change the evening dose to 10 p.m. And this is just another explanation of this. So it's basically the insulin is waning. And then this is a pamphlet that you do need to understand and read through. I'm not going to read through it on this PowerPoint, but make sure you know which are macrovascular changes of long-term diabetes and what are microvascular changes. And this page is the microvascular changes.